Good afternoon, everyone. This is Erin with the Department of Medicaid. It's just now 1 o'clock, so we'll give it just a minute longer while everyone clears out of the waiting room. Okay, good afternoon. It looks like the waiting room is clear. I was trying to scroll through, and I believe I see Wanda and Julia logged in. Did I miss any other TAC members? Can anyone hear me?
We hear you.
Yes.
Yes, I can.
Yes.
Aaron, it looks like Jordan is coming in now.
Can you hear me now?
Yes, we can hear you.
Oh, my apologies. I think I sat on my mute button. This is Erin with the Department of Medicaid. I saw Wanda and Julia log in. Did I miss any of the other TAC members? Oh, Jordan, my apologies. I didn't see you come in.
Just came in.
I see Patricia joining.
Hello.
Hello, Patricia. Okay. It looks like the waiting room is cleared and I see 4 of you. Let me just double check to make sure I didn't miss anybody. It does appear to just be the 4 of you, so you currently do not have a quorum. I can let you know if that changes.
Okay. Otherwise, we all set?
Yes, sir.
Cool. Welcome in, everyone. I think most of you are probably here for these routinely, but for those who don't know, I'm Jordan Burke, serving as the current chair for the Health Equity and Disparity TAC Medicaid. We got a few topics to cover today. As a heads up, I am currently on call this week, and so if for some reason I have to quickly take a minute, I apologize ahead of time. So I've changed the intro a little bit, and I've decided to give Deputy Commissioner Hoffman a break from saying hello to us every time, so we can just kind of try to get into things. Since we don't have enough for a quorum, we won't be able to approve minutes or anything yet, so we will go ahead and move into old business. One thing we had spoke about last time was a topic that we really hadn't gotten into yet, but was looking at the disparities in maternal health. I think that we had mentioned that apologize if I say it wrong, but Dr. Thoreau, who is one of the people that I believe that your guys like medical director or something like that, had covered that topic quite in depth before, and so I didn't know if she would be available to speak with us and kind of give us some insights into what she's been seeing and working on.
I do not, this is Angie Parker with Medicaid. I do not currently see her on the meeting. She has done a presentation for the Medicaid Advisory Council at the last one. So I do know that that she does have some information for that, but she's currently working on a dashboard for everyone that will be on our website. But unfortunately, it doesn't look like we have that presentation, Dr. Terrio. That's how you pronounce her name. It doesn't look like it
Gotcha.
sounds.
Cheerio.
Terrio. But we can certainly see about her having that prepared for the next meeting.
Yeah. And one question for sending these agendas out and things like that. Would it be easier? So like as I'm going through the old minutes and things like that and kind of checking things off that I've seen, would it be easier when I send the agendas out to kind of put the name beside of it of the person if I have like a certain question or thing I'm asking for, to have that listed in the agenda? I don't know if Aaron or Kelly are around.
You're welcome to do that. Some TACs do. I do send it to all DMS staff and MCOs when it's received before I post it on the website. It could just be possible that she had a meeting conflict and couldn't be here today.
Okay. I didn't know if that was something that's easy to work from your guys in
It's-
rather than just guessing at what I'm looking for.
It's
Well, I
your
can-
preference. Oh, I'm sorry, Angie.
I'm sorry, Aaron. I was just gonna say, for me, sometimes I do have to go back and look. I ask for the minutes, so I'll make sure that I am addressing things that were brought up at the last meeting. And sometimes I'm a little delayed in reviewing those meeting minutes, but it doesn't hurt to maybe elaborate or assign a person. But yes, as Aaron said, she does provide the agenda to all of us, and we do look at that, but sometimes we may not have, if we haven't participated in the last meeting, we may not know what exactly the request is.
Okay. Yeah. That may be something in the future that might be a little easier to work out, especially if I have some specific question I'm trying to get to. Okay, we can move on. If she were to join later on, we can ask, or if anyone else that's here, it isn't her, has been working on that and can discuss some things. I'm also open to that. Okay.
Sorry, Jordan, this is Erin. I do have a presentation that she shared with, I believe, the children's TAC last month. That's on our website. So I'm happy to send that to you guys if you would like to see the presentation Angie was speaking about.
Sure. Yeah, it won't hurt to review it. Okay, we can move on. A couple of topics we had talked about last time and we got some information on was interpreter services and the grievance processes. For interpreter services, I think the thing that we had been trying to pin down was a quicker and more accessible way for people to get in contact with an interpreter rather than going through the like the entire service line. I think that was something that one of the MCOs basically said, that wouldn't be possible given how their setup is, but a couple others had commented that might be something they could work on to try to get a more direct line. I don't know if any discussions have happened with that with the MCOs and if there is anything that they're working on at this point.
Do any of the MCOs want to speak to that are on the call?
And if not, that's fine. We had
Like when I.
Oh.
Oh, sorry.
No worries. We had spoken, or Dr. Figaro and I were talking before this one a couple weeks ago. And although we had gotten all the information sent to us, kind of, the background on how the current services are set up through interpreter services, we were wondering if there was a way that we could, get a presentation from the MCOs, maybe at the next TAC meeting on both the interpreter services and agreements processes, just because it's always helpful to kind of review the process they have in place. And so if they were to discuss them with us, maybe we could look at some things, maybe pitch some ideas on ways to improve. I saw that I think it was United Healthcare had tested the actual time to see, like, once you call the service and you go through the different directions and things like that to actually get to a interpreter. They didn't put a specific thing down there. I could have tested that myself, but I don't want to, necessarily tie up their lines for calls that end with, I was just seeing how long this would take. But if that was something that, you know, the MCOs could look at, just, you know, although they have that line in place, do they really know how long it takes to get through? Is it a reasonable amount? If it takes 15, 20 minutes, that's an entire visit with the patient, right? So that's a long time. And if there is vast differences in how long that takes to access, is there any way that, you know, they could look at other MCOs, ways of how it's set up to kind of hasten that? But yes, a presentation on that would be great. Then obviously,
Jordan, I can send this, Erin again, I'm sorry. I can send that formal request out to the MCOs after this meeting
okay,
to have that prepared for the next meeting.
yeah, and obviously a direct line like Dr. Richardson has requested would be great. So if they're open to that idea, that'd be awesome.
Hey, I'm back. I'm so sorry. I know I was cutting out with my audio. Are you able to hear me okay this time?
I can.
Excellent. All right. So we actually do have a presentation at Humana that I've got ready to go if that would be helpful, and it includes a direct line.
Okay. Sure. I don't think we have any other presentations actually scheduled for the day, correct? Unless someone actually has the gear tool that's available to present today.
No, sir, I had sent out an email to let them know that the presentation would be requested this meeting. So I was not prepared for anyone to present. So give me just a second, and Leslie, I'll make you a co-host.
Okay. Thank you.
Before Leslie goes, I have a quick question for DMS. The messaging around easy access to free interpreters through the MCOs is so important, as we've talked about. I don't think I have to go into the disparity issues around language access. Is there a point person within DMS that can organize it and get it all together and then have a communication from DMS instead of trying to get communications from all the MCOs? I think if we really want, if we really want people to use it, then I think a communication from DMS with all the direct phone lines, all of that in one communication would be really helpful. Because if people get information kind of piecemeal from all the different MCOs, it's gonna not have as big of a potential impact. So who's like the DMS point person for language access? Is there one?
Well, that's a very good question. I don't know that anybody has specifically been assigned to that. But obviously within our equity and determinants of health branch being one of those things, and while we have this TAC, that could certainly be something that we look at and how to best put that information together.
Thanks.
Yeah. I think if Leslie has her presentation, she can go.
Are y'all able to see my screen?
Yeah.
Great. Thanks for confirming. Okay, so I did a little digging. I am still new to my role as Humana's Associate Director of Health Equity. So this is a great opportunity for me to learn a bit more about the resources that we provide to our enrollees, as well as to the providers that we partner with. And so we do have a direct line. What you see on my screen right now is a very brief explanation of what language assistance services Humana has to offer. So we do have the flyer that you see on the right-hand side of the screen, and I'm very happy to make sure that everybody has access to this deck. So anyone's welcome to use it. You can click on that image and it will actually take you to the printable flyer in case you want to have that available. And that might be a good resource for the DMS person that's pulling together all of the information for each MCO. We also have a page on our website that also talks about all of the various resources that we offer as it relates to our language assistance program. And there's information about it in our provider manual. So we have information published in multiple places. We also have access to an email address. So if you do still have questions after reviewing the materials that we've talked about here, you are welcome to reach out directly to the team at Humana that manages these services. But where you really want to pay attention is that phone number at the top of the screen there in green, where it says any provider who needs assistance with over the phone or sign language interpretation. You can call that phone number. They will take the member's ID from you, and then they'll be able to get you connected to the interpretation service. The great news is when you call that line, it's going to take you to a Humana associate, a real live human being who will be able to talk to you and help you, so you won't be forced to go through a phone tree. We also put together just a little bit of information on this slide about, of course, what providers also are required to provide. I'm sure everybody here is very familiar with that. And part of why we think it's really important that both we on the MCO side and the providers have access to interpretation services. It really does, as you've already pointed out, Dr. Richardson, it helps to avoid some of those disparity gaps that we see. I'll pause for just a moment and see if there are any questions folks might have about either of the slides that I've shared here. The last slide that I have, I thought this was kind of interesting just to give you a view of what we're experiencing with our Humana enrollees. Over the first 6 months of the year, we saw about 2,100 of our members who do not have English as their first language leverage our language interpretation services. So you can see what that utilization looks like on this pie chart.
Is that available, the number after hours and on weekends, or is it, how does that work?
A very good question. I believe it should be, but I will confirm for you, and I will share that information back with the person that coordinates this meeting.
Thanks.
And Dr. Richardson, is that type of setup, again, I mean, I haven't accessed it to see how it actually goes, but is that more of what you're trying to get set up for each one? Because again, you access these more than I do.
So ideally, it would be less than 10 seconds to get an interpreter. So I think that's what we're shooting for. And I say that for two reasons. One is for us, because we're so high volume, we're 80% non-English speakers, right? So we're moving. And if I have to wait 2 minutes per call, that I could have seen another patient, right? Mm-hmm. So but it's also for people that are lower volume, that are like, oh, this is going to take like too long. I'm just not going to do it. I'm just going to do it without an interpreter because the family speaks a little English. So that speed is so important. And so I think it all depends. So with the Humana line, if I'm on, if I'm on hold, 45 seconds at this spot, and then 45 seconds at another spot, and 30 seconds at another spot, then you're looking at, it's too long, because if it's a barrier. So
yeah.
So I think it just depends on testing and internally maximum, getting it as quickly as possible and decreasing any barriers.
Yeah. I guess it is hard on both ends though, right? Like if by the time you call and you give a number, or you give the patient's name, you give their, date of birth, and they're able to match that and find the interpreter that's available, because they can't just have 1,000 interpreters sitting there, waiting for one person. I'm sure they're all in use at different times. So currently as is, right, if you have an interpreter that worked at your clinic, right, you wouldn't, there's not reimbursement for that interpreter. Right. Correct. The clinic just has to pay them. Right. And I mean, that seems like, is there any particular reason why that isn't a service that isn't covered for clinics, like that having an interpreter on site isn't something that's reimbursed?
It's a good question.
Because that seems like the most direct way to decrease that that barrier, right? You no longer need to call a line. They no longer have to see if someone's waiting around. If you have the provider that's, needing that person, they're right there.
I'm assuming all the MCOs are just then connecting us to a national interpreter line. I'm assuming it's not really their staff that are answering. You're probably just connecting us to whatever your paid
Yeah.
service is.
Like a third party.
That's true. We do at Humana have some Spanish speaking associates, of course, since that is the primary secondary language that we encounter. But you're correct, Dr. Richardson, for the most part, you're being connected to a third party.
And
Yes.
so I think so in a perfect world, we would have one phone number for all of Medicaid, right? That would be a perfect world. We dial 1-800 number, we could, whatever. But if we're going through all the MCOs, we just want to minimize that time to be connected. Because I just called that number, Leslie. So there's music that plays, you're on hold, and then it connects you to an operator, and then you're on hold, and then somebody picks up. So there's still, even though it's not a phone tree, which is great, there's still multiple hold spots. When at 1 PM when I just called. So I just think we need to just keep pushing and analyzing, and everybody looking at their processes and testing them and seeing what reality is.
Okay.
But your question, Jordan, we can't afford to have enough on site. So even if I have 4 interpreters in the building, I still have to call our outside line because there's 10 providers, and there's people in the front, and there's people in nursing, and there's people in the provider room, there's people in the lab.
Yeah.
So,
Yeah, they can't be everywhere at once.
yeah.
Regulation. It looked like Rachel was asking. Oh, sorry, 1 second.
I can read Rachel's question. It said, could you use a community health worker to help with connecting to the translator while at the provider's office? And then Jonathan Scott also dropped some regulation information that I'll copy and send out to the TAC.
So I guess I'll respond to that question. So if we don't have any community health workers, we're still exploring whether or not the payment rates at FQHCs is how that's going to work and all of that stuff. So I'll tell you, if we could afford a community health worker, they would be like helping people get food and not waiting on hold for an interpreter. I just think that nobody should have to wait. It's not that it's a burden on me as a provider. I think that if we're really serious about language access, it should be almost immediate, which is what we can get in the office with our interpreter phone. I get the phone, I push the number, we pay for it, and I have an interpreter within 3 seconds. So I think that's just what we should all not settle for less than, and we're not there yet, but I think we could still keep working toward that. It should be almost immediate. Because you're talking people in the ER, you're talking subspecialists, dentist, everybody. You want that universal fast access. But baby steps are great, and continuing to look for, get those lines with no phone tree is a great first step.
Yeah, thank you for your feedback, Dr. Richardson. And I really, I'm very intrigued by your good idea that, what if we all had one line that everyone was able to dial and get that immediate access? And I don't have enough familiarity with all of the state regulations in place that I displayed on the second slide that I shared, but certainly that's an excellent idea and one that would be interesting to pursue.
Yeah. I think looks like Tabitha in the chat said Anthem also had a presentation they would like to present. If you're done, Leslie.
Yes, thank you so much.
Hi, good afternoon. Let me share my screen. This is our presentation as well. Give me 1 second to share. Are you all able to see that screen just yet?
Can now.
Alright. Okay. Okay, so for Anthem Medicaid, just a little bit about our interpreter services in line as well. As you see, we have, I'll go here, as far as everything that we are presenting today can be found in the member handbook as well as online. Those services are available for our member services line is available 7 a.m. to 7 p.m. Monday through Friday. So anyone who is seeking interpreter services, they can contact our member service line to be able to get those, as well as if they need translation of written materials. So we do have that available. And of course, any and all of our interpreter services are provided at no cost to any of our members. As far as different types of services, we do have the face-to-face available so that an interpreter would be able to come into the offices if necessary. That does take some lead time to request that service for an individual to be on site if needed, as well as sign language if that's necessary. We do have telephonic interpreter services available. And also we have associates who are members speaking as well, Spanish speaking as well. So if an individual does not speak Spanish or needs an additional language, we do have that available, as well as our nurse line. So that there's interpreter services available for that, as well as for hearing impaired. Our providers are able to also contact our case management department and request interpreter services. There's a form that can be filled out for that or called in as well so that you can request those services. Again, as we were talking about before, we do have different types of alternative formats, so Braille, large print, or audio. If those are needed, we definitely can offer those upon request.
Yes, I was, then I got kicked off, then I got back on, then I couldn't hear.
And then we'll go to
If
the
you're not
next.
speaking, please mute. Sorry about that.
Okay. And then of course our primary language is English. We do also have 5% or more of our population that speaks Spanish. So we do translate our materials both in English and Spanish. And those are available on our member web portal if necessary for anyone. Utilization, we had 80 members that were from 2022 to 2023 that had requested translation services. And so there's the breakdown. That's January through July of this year. And then we also had 287 requests for face-to-face services for our individuals for that. Various different language requests. You see there, we have about 13 or 14 other languages besides English and Spanish that have been requested, and we were able to offer those services utilizing our interpreter language line. And then I think there was a question that was about grievance and how we go through the grievance process. So we've included that as well. Members are able to either call us via our member services line and or write in a formal complaint. You can submit those to this phone number or an address, and we do respond to those. We have the information that's available as far as how you will receive notification. So within 5 days of receiving the complaint, we will notify you that we've received that. And then we'll also let you know how we have resolved it within those 30-day time frame. If for some reason a member is not happy with the information that they received or the resolve, then they are able to take this to the Medicaid Managed Care Ombudsman's program as well to seek further assistance. And they can also file via a form. So there's another form that all MCOs use, and they can fax this form in to us directly as well, utilizing the different modalities. And that's our presentation.
Can you go back to the phone number slide?
Sure. Absolutely.
And
I'm sorry. Let me share.
reads that that's what the member calls, but does the medical provider or the dentist or behavioral health call that same number for interpreter?
That's more for the member calls, Dr. Richardson.
Okay, so who
when they call in. I know what you're asking for. Most of the things that we get that deal from the provider actually they send in the forms to us so that we can get the interpreter face to face in the office.
so we definitely need the option to call in, ideally.
I know we don't have the option right now that you could call directly in and have an interpreter on the phone within 10 seconds. I know that for sure. There's and I know you're kind of in that Iroquois area. I know you have a lot of refugees in that area that you're seeing. So
Is there a number at all that providers can use? Say if somebody's having a mental health appointment or dental appointment, is there a number?
Most of the ones that were like on that list of where we're showing that where the face-to-face, most of those are coming from either behavioral health or from like speech and OT, PT types of services.
But there's no telephone option right now.
There's not a telephone option to just pick up the phone if somebody walks into your office and you have to call and have an interpreter service.
Is that something you are talking about internally as a possibility?
It would be something we would have to talk to our subcontractors about, because most of the MCOs are, I'm not sure about Humana, but a lot of them have, subcontractors who actually, do those services. So that would be something we would just have to talk to them and also look at what I would be surprised, the 10 seconds. I know what you're I understand, because, I ran the Home of the Innocents and we saw a lot of different refugees, but also our population. And it was tough to always have a face-to-face. Sometimes we were able to get the face-to-face, of course, because we had the schedule, so we knew who was coming in next week and all of those types of things. But it is a challenge in the office, as I understand. We ended up having to actually get our own contract with Catholic Charities and then also with Pacific, I think it was called Pacific Interpreter Service, to serve the members as they came in the door.
Right, that's what people are doing now, and we're trying to move away from, because there's so much inconsistency among offices, and so we want that really simple, straightforward. This is how you get it.
I understand that, Dr. Richardson. I understand where you're coming from too. So it's kind of a hard balance, I think, between walk-ins, emergencies that come in the door, and how to handle that too, or last minute scheduling that somebody canceled, and that's another whole issue within itself.
Yeah, and it's not so, and I just want to be clear, it's not so much we've got it figured out. It's extremely expensive, but we've got it figured out. I'm worried about my patients that are at the emergency room and at the dentist and at private subspecialty offices that still tell people to bring an interpreter with them. I think DMS needs to know there are still practices that say we will not use an interpreter. They have to bring an interpreter with them. So that we're still there. So we want to move away from that.
And so if there is some specialties that are doing, they can, and usually the specialists will have schedules, pretty much set, and we do have a way for them to get a face-to-face person. So I'm not sure where the disconnect is with that piece, but thank you for bringing that up.
All right. But the other NCOs at the next meeting want to present theirs as well, so we can look through how their things are set up. That would be great. Again, looking at disparity and equity, as Dr. Richardson said, I mean, that's a key point. Is communication obviously is so important with people's health care, making sure that things are clearly informed to the people.
When we get, I just wanted to, sorry, Dr. Burke, we will get that information that the MCOs have been providing and see if we can find a common thread with that as well. We'll look into that.
Great. Same with grievance processes. We had gotten the huge file going through each of the different grievance process setups for the different MCOs. So I appreciate Anthony for showing at least a little bit of theirs. I mean, it seems fairly dense material on how the whole thing is set up and the timelines, and and I'm sure that for a lot of members that's a difficult thing to work through if they are trying to file a grievance. This is sorry, I was reading chat real quick. Yeah, Leslie was saying that she thinks that goes against some regulations requiring patients to bring their own interpreters. So that's why having that grievance process being easy to access, so they can bring something up like that up if that's a problem they're facing, would be great for the patients. But yeah, if MCOs can present some on their grievance processes at the next visit, so we can try to figure out a way to maybe streamline that or just make it easier for patients if they are experiencing those problems. Care gaps was something that was brought up at the last visit. I think it was actually Stuart Owen who had mentioned it. He said that because Katrina had questioned about certain people she going to certain providers and not experiencing the care that they should, and whether that's just that provider or if there's possibly like an underlying, whether known or not, bias for how they're treating their patients, which results in different healthcare outcomes. And he said at one point that they can see the quality measures and things like that for patients, but he said, I believe at one point, that it isn't broken down by race or anything like that. I didn't know if that would be something that could be possible to access data on, not to like villainize or demonize providers that if they have large gaps, but at least so the providers could be shown the differences in outcomes, whether patients of certain color are having different outcomes at their own clinics versus others, so they can review their processes and try to improve them. I don't know if that's accessible in the data. I know that you guys had said a lot of the problem is that race and stuff isn't put into that information, so I don't know if it would be accessible or not.
Are you asking this of the MCOs?
So I guess, yeah, do the MCOs, when they look at care gaps for providers, is
Is it
there a
broken out
way?
by race? Mhm.
Yeah.
Well, they should have that capability if they have the information. And they are to be tracking that if, they do have challenges like we have challenges in the tracking of persons' race and ethnicity. But if they're currently doing that, I would have to defer again to the MCOs, but that is something that they should be able to break down within their systems.
Yes, this is
Reporting.
Tabitha from Anthem. In regards to that, that is one of the things that we're able to do is you look at stratification based on race or age or gender. So different things as we're looking at some of those clinical outcomes to see how we can better improve those as well.
And are you guys looking at that from like a region perspective or provider perspective or like institution perspective to see if there are areas that clearly something is different at that institution or place versus others to try to improve, or is it more
Yes.
statewide that you're looking at?
Yes, so we have taken the approach to look at the member specific, so looking at the member, and then we're also looking at like geography, so maybe where they will be. Future steps of what we're looking at that we would like to. We have the capability right now, but we're wanting to delve deeper into that as to be able to match those to the providers as well, so you can kind of see, if there are opportunities within each one of those, how can we best help support those individual providers to help the members to be able to close those gaps.
Okay. Again, I think it's something we've kind of talked about from the beginning, is that there's a lot of data that you can get or retrieve, but it's, how do you interpret it or use it at that point? I think that I've seen that a lot between last meeting and this one, because we've got many different things sent to us, and I'm trying to just figure out the best way to actually reason through them, which goes into the next one. We got some information from the out of care or out of network utilization from the different MCOs. Thankfully, it looks like they've given that information to another TAC as well, so more accessible. I was trying to look through the numbers, and I don't see any specific patterns necessarily that says that, one area is more of need. There was a like a pretty vast difference though. One of the MCOs had only had, I think, less than like 100 of these single case agreements, and others were like in the thousands. I don't know if that was specifically because they have more providers in their network, or if for some reason they're only centered in the middle of the state where people don't go as far. I don't know. But I thought that was interesting, at least. I can't remember the exact one at this point. Yeah. Anything that anyone else had seen when they were looking at that that stuck out to them as far as, what was being accessed out of state? No. Yeah, me neither. I thought it'd be useful, but when I looked at it, it was kind of just nothing. Okay, so immunization fee adequacy. I know, Dr. Richardson, you had sent me a little bit on this. It was fairly recent, so I didn't get to review it as much in detail.
Yeah, I think we're just communicating back and forth, the team on the email group. I'm still waiting to hear from some community-based providers on what their contracted rates are for vaccines, just so we can get the most up-to-date comparison for some of the more expensive vaccines. So we will keep reporting back.
Okay. All right, and then value-added benefits was like another little area that we had discussed at the last meeting. I didn't know if anyone had any thoughts on, additional ways to try to use those. I know, Dr. Richardson, you'd mentioned, value-added benefits aren't always something that moves the needle, but is there a way to kind of change those, or ways the MCOs can kind of collaborate on what actually is effective? Even though, I'm sure ideally they offer different services in order to be like more unique and to try to get certain patients to go with them. It's best if they're actually using those types of things. So are the MCOs looking at, like we've had this information sent to us, and right, it looked like the gas cards and things like that were really used, and there were other services that weren't. Are they reviewing those types of things to try to make value-added benefits and stuff more enticing for patients to use, to access things, or is that something that isn't currently being looked at?
This is Tabitha from Anthem. Yes, that is included in part of our strategy. And when trying to see, what are those benefits that are going to be the most beneficial to be able to help support those members? How can we best improve their health outcomes? So matching what value-added benefits could support those. So things like you mentioned before, the gas cards. If we can help to be able to provide the gas cards to be able to connect them to get to a doctor's office, that's something that we're going to do. Or is it something that we have as far as maybe an air fryer or something like that? How can we make sure that healthy cooking can be connected to chronic conditions and supporting those? So we do look at what we're offering and how they are actually going to benefit the member and their health.
And I'll second what Tabitha said. We at Humana are also evaluating constantly, what does the utilization of our benefits look like, and trying to break that down by our enrollee demographic too, right? So if we were to find out that, only members who are based in Louisville are using a particular benefit, well, then that tells me there's a gap. And so how can we potentially close that gap for our members who may live in other parts of the state, or whatever that disparity looks like? So we're also, always trying to make sure that we're providing the most appropriate benefits that are going to be of the best use for our enrollees.
Okay.
I would just add, I think this would be a really interesting thing to really look deeper on. I know it's so hard, right? So we have Medicaid, but then we have all the MCOs. And I think that sometimes it's hard to look at it from a big picture perspective because we have all the details of all the programs from the MCOs. But as a tool, as a Medicaid tool to improve equity, is there anything that we can ask the TAC for, something like that, to say, okay, let's go up a few levels and say, all right, so let's look at the programs as a whole and have they had an impact, and what some strategies could be, sort of looking at the state as a whole. For example, I love the idea of value-added benefits. My patients don't, I've mentioned this before, no, but like I'll show them these things I pick up at meetings and they have no idea that they're available for their children, even for the well child visits. So that's just one example of, you know, as a strategy for the state to improve health outcomes, how do we work better to get it in front of people? I don't know, just as an example. So I guess my question is there a way to look at it from a higher level to really analyze the impact on equity using healthy value-added benefits as an equity tool? Because I've gone to meetings and I've been told that the uptake is less than 10% across the board for all value-added benefits if you look at everything.
Yeah, I think you're absolutely right, Dr. Richardson. And I think that sometimes, you know, enrollees are confused about what is something that is covered by standard Medicaid versus what is it that, you know, Humana offers versus what Anthem offers. So I think you're right that that definitely contributes to low utilization rates. And I really appreciate what you're proposing here about, could we look at it from a statewide perspective? Maybe some of those value-added benefits should be part of what is covered standard by Medicaid across the board. I think it would also be really helpful, and this is something that I'm looking into for our Humana enrollees, but you know, I think everybody would benefit. Do we know exactly what it is that all of our enrollees want and what they need? You know, I've been an employee of Humana for a very long time, and periodically our human resources department will survey us and allow us to give feedback on what kinds of benefits are most valuable to us. And so I think it would be really beneficial if the state would be interested in partnering with us as MCOs to also get that kind of broad perspective from all Medicaid beneficiaries. You know, we do that individually as MCOs. We survey members, we talk to members, but I think that seeing it from a statewide perspective really would be helpful.
And then maybe not having it bringing up to DMS paying for it, but having some DMS mandating certain value-added benefits. I don't know if there's any of them are mandated or, but if we know that access to a cell phone is universally important, then why can't all the and maybe all the MCOs do that, might not be a good example, but having some common, more easier to understand.
So Dr. Richardson, this is Kate Miller. I'm the whole health director at Anthem. One of the things, and I don't know, Angie Parker, you might know the answer to this, but I'm wondering if there is the capacity to maybe have a QR code that all doctors could hang in their offices that says, do you have Medicaid in Kentucky? Do you need help? Scan this QR code. And then the QR code then goes to like a landing page where then they would click, I have Anthem, I have Humana, I have WellCare, I have Molina by Passport, you know, like whoever, United, I'm sorry, I'm trying to not leave anybody off, Aetna, you know, like, and you click on then your particular Medicaid insurer that then would take them to things like the community resource page that every MCO has, you know, for their members to have, has, you know, click here to access your healthy rewards. Like each MCO would be responsible for doing their own page, but if we could have like one landing page that could have a QR code that all providers could hang in their office, and then people could be directed to it. I don't know. That's just my vision for the perfect world.
If we only lived in a perfect world. But no, Kate, it's obviously something to potentially explore. That could be something we would add to one of our population health or quality meetings to kind of discuss.
Yeah, I think,
I mean, sometimes you have to look outside the box on things, and so
And I think that all the managed care companies would be happy to come together and make that happen. I mean, I think that that's something that benefits all of Kentucky. That's something that we all could, lock arms and play Red Rover, and make that happen. So.
And I think this goes to speak to, this is Tabitha, sorry, with Anthem again. I think it goes back to Dr. Richardson's comment about just communication and people knowing about different services, right? So not only would it be something, maybe that QR code would be able to be in our provider offices, but, maybe our community-based organizations, as we're expanding this, like putting it in the places in which our members or enrollees are at, so that if you do have that opportunity to scan it, then you are made aware of the services that are available to you, because that's a place that you frequent and it's somewhere that's in your community and you're not having to go outside of that to receive that communication. So just thinking about more awareness and communication that would be broadly to the membership as a whole.
well, not all members go to a provider office, but I mean, as I said, this is something that we can explore. Obviously, we do rely and expect the MCOs to communicate with their membership. And if they have certain programs, that they are alerted to those. Generally, in open enrollment, we do send out to the Medicaid members at that time. It's open enrollment time. And we include the value added benefit mailing with that open enrollment information. So if their address is correct and it gets to them, the members do have that side-by-side value added benefit page that compares all MCOs. Is it a perfect system? No, but I do appreciate ideas on and how we could potentially think outside the box in some of these areas. And we can certainly have those discussions and our MCO equity meetings as well.
Sorry, I got caught up in things for a minute, so I missed part of that. Sorry. What was the overarching theme there? I was dealing with a couple texts and stuff for hospital. If someone doesn't mind to recap that real quick.
Looking for ways to improve education or notification for the members to know what the benefits or the value added benefits are. I think is the overarching way to how do we can improve communication so that they know that they can get a gift card or a gas card if there's a low utilization towards those types of benefits.
Yeah. And
then I would also say associated with it, and I apologize, Dr. Burford, is what are the outcomes of those value added benefits?
With how they're set up now, I know that like some of them are like if someone's had their well check or if they've done things, is it they have their well check or they meet some criteria and the value added benefit is automatically sent to them, or is it something where they do it and then they have to then go and request that they receive the benefit?
That depends on the MCO, and that is a challenge. I mean, if a claim comes in with the well child visit, some MCOs will automatically send that value added benefit to them. Sometimes the members have to go in and do something special. So when I say something special, they have to go to their website and sign into their wellness program or something to that effect. So that could be part of the low utilization in some areas as well.
Yeah, and I can share an example, from Humana's perspective. What Angela just described is true, right? So if you receive a service that is claims based, we will automatically issue the associated reward to our members. They don't have to take an action. They get it automatically. But if you are taking advantage of a benefit that's outside of traditional healthcare claims, so for example, we offer free haircuts for kids who are going back to school. Obviously, there's no claim for that. So that is the situation where we would require our members to let us know that they took advantage of that, and then we can then reimburse them.
Gotcha. Okay.
And then just to one final word on that, I think the bigger question for us as this TAC is there evidence nationally that value-added benefits promote equity? And so I think if there's a lot of evidence that shows that this is an important equity tool, I think then it may give us more strength to the work that, oh yeah, this is one of the, nationally, they're saying that value-added benefits really can change the landscape for people around health equity. Then I think, but if it's like, doesn't really work, then it's a nice thing to do, but not like a priority. So I think that would be another question to continue to ask, because we know right now despite everyone's best efforts and lots of time and money spent on these, we know the uptake's super low. So it's going to take a lot of transformation in these programs to increase uptake. And if there's not a lot of evidence that it improves equity, then, just thinking about prioritizing.
Well, you can certainly look into that. I'm not sure specifically equity would promote health equity, but potentially health outcomes, but we don't know that either. For sure. So something to review. I do know, they'll give free diapers if they participate into a maternal health program. And that helps with, hopefully improving outcomes for the birth and pre and post. So there's a lot of that falls into that.
But I think when it comes to equity, there are two things that continue to be persistent as barriers. One is language, and the other one is the geographical barriers, say rural communities and things like that. And I think that I know that we want to quantify everything, and that would be our first choice. But there are some things that it's difficult to quantify, to look at what is the impact other than the experience of people coming into the program and having regular checkups. A good example of that is domestic violence. We can expand partner violence, prevention, shelters, and all of that. But that is not, we might not expect to see a drop in the number of people accessing those services, because it might be that once the services are available, more people are going to request it. It's not that you have a higher incidence necessarily. So the impact is not necessarily measured by a decrease on something. And so when it comes to language, I know that people are coming to are requesting services, but when we don't have the language capacity, that's a huge barrier. Or when we encounter like different communities, whether it's Spanish speaking or Burmese or many other communities that are dealing with difficulty in accessing services or hiring clinicians who are bilingual, that we have to work in access to services in a way that they feel heard. To begin with, you cannot do healthcare without seeing what people need, and so I think that we should not focus so much in the numbers at this point, demonstrating the value of it, because that has been demonstrated already. we should look at the impact based on whether the MCOs have that capacity or build that capacity, whether providers are able to get a differential in because language is a specialty in the reimbursement. When you have someone who's bilingual, I mean, we establish a differential pay in order to attract that. But somehow, someone needs to pay for it. And so one, I advocate in and continue to do so in improving access to language services. And the other thing is to valuing the skill of those individuals who are bilingual so we can retain them as healthcare providers.
Yeah, no, I mean, we talked about language, I think we talked about it the whole time, the importance of those types of barriers. That was all for old news that I had. There was a couple things that we got sent recently, but we can touch on those in general discussion if we make through. I know that the Gear Tools presentation has been on here for a few now. Anyone that is able to do that today? Has there been any updates or things? I know it was an ever-changing project the last time we had reviewed it.
Well, I do know, initially when this committee started or the TAC started, that our Deputy Commissioner Hoffman and her staff had done a GARE tool, all of it, and discussed what it was overall. We are looking at, and we're hoping to have someone who is an expert in that field to kind of go over it. I mean, we can show you what the GARE tool is, but hopefully by the next meeting, we can kind of give you more of a general oversight again on what that looks like and how it can be used in health equity. I apologize, it's being kicked the can for another couple of months, but
no worries. Dr. Richardson, that link you had just sent, what's kind of the, I can't read it all right now. What's kind of the summary for what it's trying to say?
Yeah, it's just sort of, it's that same question of do patient incentives move the needle? And they're like, maybe not. The evidence is not overwhelmingly positive.
I'll try to keep the link to review it after. As far as the MIC goes, do we have any updates on that or where we're at with how things are going?
we do. Danita Coulter, who's the equity branch manager, is going to discuss that. I'm hoping.
On my unmute button, I'm sorry. Just for the most recent updates for the MIG, of course, we recently had our showcases. So with those showcases, the MCOs showed some interest in transportation as the option. One of the innovators in particular that they expressed interest in was called Kaizen Health. So we did have a follow-up meeting with that particular vendor just to find out some more details about what their transportation option looked like and to just answer some of those lingering questions. Right now, I don't know that we have any of our MCOs that have moved forward with establishing contracts with this vendor. We wanted to make sure that it sort of was not going to be a duplication of some of those barriers that we see with transportation right now. Other than Kaizen Health, I don't think that we've moved forward with any of the other tech-enabled solutions. We do have another funding opportunity that developed from the Innovation Showcase. So there is going to be additional funding for a pilot that is going to focus on a subset of people that are insulin requiring diabetes, type 1 population. So there is a potential to fund for the MIC to pilot 5 programs, and that's through Kentucky, Iowa, and New York. So those applications are pending. They will run through September is when they will announce who will receive those funding. So it will be the potential for 100. It's going to be a small pilot, so it'll be 100 Medicaid members if Kentucky is selected. So right now for our MCOs, we do have 2 MCOs that have reached out to us that have expressed interest. So if they decide to pursue the application, again, they would have to choose a vendor that was involved in those in the innovation showcase. So any of those vendors, Dr. Burke, that we looked at through that list, those would be the potential people that we would partner with. Outside of that, the other things that are going on with the MIG are that they are continuing to provide the technical assistance calls. And we continue to have those state calls where we just do our regular check-ins to see where we are. And if we have any additional supporting questions for the MIT team.
Great.
Anita, this is Leslie with Humana. Thank you to the MIC for making it possible for us to connect with some of these groups. We are very interested in being a part of Kaizen's application. And we had an initial discussion with Mindy Knabel, their CEO and founder. And she mentioned that she would be connecting with us and a couple of other MCOs to talk about how we could issue a joint application, since we know that those applications would be, preferred if we have more than one MCO involved. And I'm having a hard time getting Mindy to, help me get back with all the other MCOs and get a date on the calendar for us to chat. So I didn't know if maybe you knew more than I did, or if you might help point me to somebody on your team that could help get a group discussion together, but we're definitely interested. Oh, and it looks like you might be on mute. I see you talking.
Yeah, sorry about that. If you can include myself, Angie, and Leanna on your communications, we can look at that and see what we can do to try to connect you to. She should be reaching out to you directly to help facilitate this, but I can reach out to also facilitate something with the MIC director to see if she can help get things moving with you all.
Thank you so much. That would be wonderful. You said send a note to you, and who are the other 2 folks?
Leanna and Angie, just so that we're all in the loop, so that we're familiar with the conversation. That would be great.
Excellent. If y'all wouldn't mind to just drop your email addresses in the chat, I will very happily do that. Thank you.
Thank you.
Good. We had talked before about health disparities reports and things. I know, Angela, you said that you guys were still kind of parsing through things and trying to put some reports together to see even where to start. What have you guys been looking at so far? And is there anything that you do have data-wise that's starting to stick out, or still kind of in the process of getting things?
Well, we went through the transportation presentation last month, and Rachel had provided some follow-up from that to Aaron, and I believe Aaron was going to share that with you all. There are so many things that stick out, but we are currently looking at homelessness and see what we could potentially, we may or may not have something for you by the next meeting, but in general, we're looking at everything and where we need to target specific areas, but every area needs to be targeted. So it's a work in progress. And also with Danita, you know, she's been the lone person within her branch and she's getting ready to hire a couple of people. So we're hoping that it will help facilitate a lot more information as well.
Julie, you unmuted. You got
I was
something?
just gonna ask on the, just the, reporting out of the system on health disparity. So, can we look at it? Do you have anything we can look at maybe next time, even like diabetes rates and the race and ethnicity data, or you know, anything, just to kind of get our eyes on some of the data, even though we know it's not 100%.
We'll see what we can do, Dr. Richardson. I mean, if that's what you're looking at, until we can get like more of a social determinants of health type report, we want to look at diagnosis specific and what we can pull from that.
Does anyone have a particular diagnosis that they'd like to?
I mean, when you talk about things like anything that falls within the metabolic area, right? Whether that's hypercholesterolemia or diabetes or rates of heart attacks, strokes. I mean, all those things are what we anticipate will look, you know, like there's disparities in it, but having some actual numbers is always nice. See, looks like, not to put her on the spot, looks like Dr. Terrio did join. I don't know if she would be able to comment on the things we had spoke about earlier about, it sounds like she had done something with the disparities in maternal health, if she's there.
Hello, I'm here.
Hi.
I'm sorry I'm late, but I figured
No worries.
I'd still be on if I got on it too. What questions did you have?
Someone had mentioned at the last meeting that you had previously presented, and you do a lot of work in maternal health. And so we know that one of the areas that's a problem is that women of color experience far worse outcomes in many different areas and have higher mortality rates. And so just seeing what work's been done on that area, that you got things that you guys have already looked at, or if there's other questions we can ask to maybe help out, given what this TAC is.
The main thing really that's happening is working with the Kentucky Perinatal Quality Collaborative, and that is trying to make sure everybody gets high quality care in hospitals. So there's no discrepancy between the care one individual gets compared to another. And they've been working on trying to get people to postpartum visits, after they deliver. They've been working on a hemorrhage bundle so that everyone's blood loss is treated the same way and counted the same way. So different things like that. That's kind of like the frontline stuff that's happening, because the disparities with maternal health, I mean, it's the same hospitals, the same providers, the same staff, everything's the same, except for white women are doing better than women of color. And so the bottom line is the system is treating them differently, probably based on the color of their skin. And to fight that, you kind of have to set up protocols and treat everybody the same way. To me, that's a little lame, because how is that gonna, it seems like a long haul to do that, but you can do it along with your implicit bias training and other training, staff trainings and things like that to address the issue. But right now, we're trying to define the problem. We're working with Department of Public Health and the PICUC, and I'm just trying to do what we can do.
Good. Now, you said they're trying to implement these things where people are treated the same across the board. Are there any facilities that have already implemented that, or are there places that have previously implemented that where it had successful outcomes that you guys are basing that off of?
It's an ongoing process, but the ARHs are all of the ARHs, or what's ARH stand for?
Appalachian Regional Healthcare?
Appalachian Regional Healthcare, thank you, is and they're all participating with the PICUC. We have a Norton's Hospital participating, so there's different places around the state that are participating. They have to have a leader, they have to be able and willing to start some of these programs in their hospitals. It's basically QI projects in hospitals and focused around labor and delivery.
Do you know if Kentucky specific versus national, how the disparities here compared to other states? Are we about average or worse or better?
We're about average. We're not any worse.
Yeah. Which isn't still not saying much, I'm sure.
Very much, yeah.
Okay. Had you done a presentation for a different TAC or group on this subject before?
I think I had a very short presentation for the nursing TAC.
Gotcha. Do you recall like any specific highlights or things like that that you had from that?
Dr. Terrio, I have it pulled up if you'd like for me to share it.
Sure.
I was going to email it to the TAC.
We can go through it and see. There's probably some good information. I think when we did it, there's some national comparisons on there. Let's see. Am I able to scroll down or no?
I can scroll for you. Can you see it?
Yes, we can see it.
Perfect.
So some of the stuff you guys already know. And this is just in Kentucky. So Kentucky is 87.5% white, 8.5% black. Yet of course the pregnancy related deaths for our Black women are much higher than our white women. And go ahead, next slide. And again, this is from the Kentucky Maternal Mortality Review, and it's looking at the difference in maternal deaths from any cause. So whether it's pregnancy related or not, based on race. And you can see a big difference between deaths for Black women versus white women.
Do you know what causes are encompassed within that they're looking at?
All cause. So that one was any cause. So if you got in a car wreck, that would be counted in that, as well as like a postpartum hemorrhage. So that was all cause. And so we had some good news coming up. So if you scroll down a little bit, this one is pregnancy related deaths based on race. And if you look, still we have 40 per 100,000 versus 13 per 100,000 for the pregnancy related deaths. So the related ones is you wouldn't have died unless you were pregnant. So, or because of the pregnancy, that includes the postpartum hemorrhage, sepsis, those things that happen because of the pregnancy versus a car wreck. So this is just pregnancy related. So it's still a difference there. Pretty big difference.
And is that number at the bottom so it says N of 2, so the total number is 2, but the rate puts it at 40?
Yes.
Okay.
And that's from the most recent maternal mortality review that came out last November. And then this one is looking at the underlying causes of death. And this is from 36 states that submit information to the CDC. And when you have a maternal mortality review committee, that the CDC wants everybody to use the same form, so they're gathering the same data. So 36 states are using the same form to gather this data, so it's more standardized. And we are one of those states, and so that's why it says 36 states. But when this is looking over, several years, but you can see 22% of the deaths, of the pregnancy-related deaths, are from mental health conditions. And then the next slide, if you look just at Black moms, what is it? Coronary conditions are the highest. So that's right at about 16% as the cause of death. And cardiomyopathy is 13.9%. So if looking at Black moms, a lot of cardiac issues are causing their death. And then just the flip side is the next slide looks at white moms. And most of the time, the cause of death is a mental health condition. So interesting. And then going back to just real quick, the PICUC and why we're focusing right now on, for example, the maternal hemorrhage bundle. You know, if the leading cause of death for Black moms is cardiac related, then that should help. You know, focusing, you know, that's an in-hospital thing that happens. And if you treat all the moms the same way, weigh all the pads, you know, do whatever you do to assess bleeding, and have standardized protocols, that should help address that disparity. And then this slide is just looking at the Kentucky maternal deaths, basically all cause over time. And the rate is still per 100,000. And you can see it's just going up a bit. And in Kentucky, we have a lot, about 52% of our moms, of our deaths of our moms are substance use related, about half of them. This one is just really showing the changes, you know, again, over the years. And I don't know if you can see it, but as you move towards the gray, the brownish gray color, it's, you know, moving towards 2001. And just looking at it over time and how it really, it's getting worse over time, but the racial disparity is still the same. Like that doesn't seem really to be changing. And it's almost done. Let's see. Oh, and this is just to show, and this is a CBC slide too, that as, you know, if your pregnancy outcomes are different, Black versus white, well, then your preterm births are going to be higher for Black women and your low birth weights are going to be higher for Black women because the pregnancies are not as healthy as the white pregnancies. And so this is just the preterm birth rate showing the difference in race. And then the next one, I'm sorry, is the low weight with the difference in race. So Kentucky is kind of right on the national stats. So we just have to improve. We have to keep working on it. We have to address it, number one. And then we have to try and figure out ways to address it.
Yeah. It'll be interesting to see, you know, how the postpartum hemorrhage protocol that's implemented for all actually impacts. I mean, I think at least in theory, that's like a perfect example of like equitable healthcare, right? You're doing something that will improve health for everyone, but will disproportionately improve it for those that are most affected by it. So, you know, I think that should be like what we try to think of to do for other things.
Thanks,
Okay.
Aaron. Thanks.
Yeah, thank you. Appreciate that. I think that goes through most of the topics I had on here. We had recently got a couple of things, so I just had some questions. I seen we got something about the 1915I at SPA. I didn't know if there was anything that you guys wanted to mention about that. Oh, Rachel's got her hand up.
Yeah, sorry there, Jordan. Before we get on to that, the report that was sent, just to recall, because I know it was a holiday weekend and you all had an influx of emails, but the transportation PowerPoint on that disparity that was done in July, there was a report sent that was an update on the questions, the follow-up questions, the covered services, things like that. So that's in your email. But I wanted to ask, in addition to that, for the next TAC meeting, we can certainly look at diagnosis codes and what have you. But we are already in a project working with different agencies and getting information on homelessness. So it would have a lot more meat on its bones if that's something that you all would like to be presented with. That's a project that we're currently working on that we should have done by the next TAC meeting, if you rather go that direction rather than diagnoses.
Yeah, I mean, I think if you feel as if it'll actually be more impactful as far as what it would provide for us to get, you know, something tangible to do something with, then I think that's reasonable. Yeah, I looked through the NEMT transport thing and have an interesting point from it, but I was just going to ask about, you know, if there was anything for this the spa that we had been sent from Aaron. It was just this morning. If there was anyone that wanted to touch on that and exactly what that's going to be doing. Is that one of the ones that we've spoken about before? Because the serious mental illness and substance use disorder. Was there anything new with that?
I just saw that this morning regarding that. I don't think it's been necessarily discussed here.
Okay.
We might have some more information on that the next TAC. If you want to put that on the agenda, Deputy Commissioner Hoffman or someone from her behavioral health team may be able to address it a little bit more succinctly than I can. But if you have that, if you would like to participate in that meeting, I believe that's the 25th at 10 o'clock and listen in on that. Might be a good opportunity if you're available.
Okay.
1915I waiver.
Yeah.
Because there was a Senate joint resolution that was passed for us us as in the cabinet and Medicaid to see about submitting a request for a waiver through to CMS. So that is being evaluated. That's the limit of what I know.
Okay.
And is it
Dr.
out?
Terrio may know more. Yes.
I think they said it was out for public comment in Tuesday morning meeting.
So I sent out 2 communications for the TAC members. From time to time, I get communications. They asked me to send to all the TACs. So on Friday the 1st, we sent out one for the Michelle P. Waiver public comment. And then this morning, I also sent out the 1915 iSpa informational webinar announcement. So both of those communications came out kind of back to back to you guys.
Okay. The information we've been sent over the weekend for the NEMT information. A couple of things. Tons of cancellations. That's 529,000 cancellations is huge. It did look like at one point at the top, it said the data is based on a one-way trip. If a member scheduled to and from, that would be 2 trips included for the 1 day of service. So if there was a cancellation, did it count as 2 cancellations for that, or would the cancellation just count as 1 since they hadn't went the one direction yet?
It would actually count as twice because one there and then one back from the provider, whatever service that they had scheduled. So,
okay.
Yeah.
And then on the, it said that the cancellations are mostly, you know, it says illness or no reason given for no shows. Is that the transportation provider gets to the location and then that's the reason that's typically given for them not going on the scheduled transport?
Yes, so the number one occurrence that we've been advised for Office of Transportation is when the transportation providers show up to that member's door. They had called and scheduled, doctor's appointment, they need transportation. Provider shows up at the agreed upon location, time, knocks on the door. Either the member forgot about it and wasn't at the facility or at the residence, or they were at the residence and just said, no, I don't need this anymore. I don't want to go. So there's quite a few of things like that instead of in advance calling, hey, I don't need to go to this appointment. I have it rescheduled. It's more of last minute, they don't show up. So that's a bit of a problem that we're seeing.
Do the vendors try to contact the patients in the days prior, like 1 to 2 days prior or something like that, to confirm, the scheduling of the pickup or of the appointment they had initially scheduled? Or is it, if it's like, I don't know exactly, how far out they usually plan these. I know it has to be several days in advance anyway, but is there any closer like reminder to the patient of the appointment they had set up? Or
Yes, my understanding is that there is a follow-up that occurs a few days beforehand. So that is supposed to stop that issue from happening. So I can definitely get more information from Office of Transportation to see a bit about that process and get back to you on the next one, just to make sure that we have the ins and outs understood.
with so many different vendors across the state as well.
Yeah.
Are you guys able to look at maybe cancellation rate by different vendors to see, if there's, why does this vendor have, they say they schedule these things, but they say 80, 20-30% of the time when they go there, the patient wasn't available to be picked up, but another company only has it happen like 4 or 5%. Is there anything that we could look at to see if that's happening? And if so, why is there such a disparity, and why are people in certain locations being picked up and actually taken to their appointments versus not others?
We can certainly request that and give that to you in a report similar to this fashion. One thing that's important to note on there as well is whenever we are talking about the transportation providers are under a transportation broker, and we have 16 different brokers. So it can get a little messy with getting information to go from that end all the way back up to us.
Yeah.
So that's something that would be good for us to ask for and really fine tune that information and give that to you. I think that would be beneficial.
Yeah, because I am from Knott County. Knott County has 14,000 people, and they had the third most cancellations for a county in the entire state.
And this is in a 6-month time frame.
Yeah.
Yes.
So there's Louisville, the county where Louisville is, there's the county where Lexington is, and then there's the towns that maybe you guys have heard of one of them. Probably not even one. So I don't know what's going on there, but when I saw that, I was, I would love to know why their rate, I mean, based on a per number, I'm sure that has to be absurdly, they have a third of the cancellations that Fayette County had. And although, I mean, I'm sure they request longer transport far more often, but I'm sure, I don't know, there has to be a vastly different numbers. That just really shocked me. And so trying to dig into what's going on there was most interesting.
We're doing once we started this project with transportation in general, and then, Eastern Kentucky, and doing based on the questions that you all had and follow up and what we've seen so far, we are doing a lot more digging ourselves and wanting to know, because when I looked at the data and I saw that Jefferson County, I can't remember specific, but they had a huge, I know they have the majority, they have a lot of population in that area, but still the numbers were staggering. And I was like, are we sure this number is correct? So we did ask them to go back and look at that, but yeah, we're doing a little bit more digging ourselves in this and trying to identify trends and, you know, if it's one particular person or if we can get the managed care organization information, just a lot of different, there's a lot of different ways to go with this, but yeah, it's definitely something that we need to get to the bottom of.
Well, is it like when they cancel it like that, are we sure it's being canceled by the member instead of the driver? I mean, what if they show up and they think they're gonna bring mom and a baby to the, you know, and mom is there with the baby and 2 other kids? Does the driver say, oh, I can only take you and the baby, not the other kids? And mom says, well, obviously I can't go. You know, I mean, how do we know it's the real reason it's being canceled? Because you know, I think that's the rule, that they can bring like the parent and the child, but people have more than one child.
Right. And it's up to each individual transportation provider and at their discretion if they have the seat available for the child to come with them at no cost. But that is definitely something to dive into a bit deeper and to analyze, because yeah, when we got those numbers, we were pretty shocked.
Yes.
So.
Dr. Therio, that was my question too, is how do we know these cancellations? Because what, you know, on our side, we hear the drivers cancel, right? That's all we hear. And I don't see where that data is bubbling up. However, I spoke to somebody in the community health worker world, and they said, if you want input on transportation issues, talk to the community health workers, right? Because they're working so closely with members and they may have a perspective on the transportation issue that we can't capture any way else. And so we could invite somebody from the state office or, you know, one of the representatives sort of statewide from the community health workers if we wanted to get more information, or you all could touch base with them. But I think somehow getting the members or the patients' voices in this conversation as we go forward is really important.
And a lot of times, even if they're school age kids, mom will keep them out of school that day if either they have an appointment or the younger kids have an appointment, because she physically can't be at home to either get them on the bus or get them off the bus. So she has to bring them with her. And doing everything right, you know, she might look like a no-show in the clinic and might be canceled transportation and the kids miss a day of school. And but she's trying to do everything right. And so it's hard to kind of get that kind of stuff out of the data.
Absolutely. And we will definitely work on getting an updated report with some of those questions addressed for the next TAC meeting.
Julie, you had asked me a week or so ago something to request for the next TAC meeting. But you said there was a new 1115 waiver application, and you said you had spoken with I think some others about it. What had you covered so far, and just so I can figure out kind of what you're talking about?
Just any updates on, there's a new 1115 that's been submitted, is that right?
That's what you said, yeah.
Yeah, Angie or Judy, or is there a new 1115 that was submitted?
There's a lot of 1115s going on.
Well, mobile crisis is one, and it's still in procurement, so I can't really talk much about that.
Incarceration is another.
Mm-hmm.
They're all working through the system.
And so until they're through, we can't really get any updates. Is that what you said?
On mobile crisis, because it's still in procurement. We can't talk about things that are in procurement necessarily. So, but we're still looking at hopefully signing a contract in the very near future.
You also said you'd spoke with someone doing research with the AAP for equity and quality for Medicaid.
Yeah, I sent you
Yeah.
those reports just to Jordan, just for your information to
Which
see.
one were they? Were they the ones you had sent me this morning?
Yeah, yeah.
Okay, yeah, I have not looked
So
at those.
I guess no, just I guess on 11:15, just if you can update us next time on anything related to our work.
Yes, I would just make sure you put that on the agenda.
Okay.
And we'll make sure we have somebody here that will address it.
Okay. And you said which 11:15 is that specifically, Julia? Or
I didn't realize there were so many, so I guess anything that pertains to this work would be great.
okay. All right. Any topics for general discussion? Things people have thought about or seen since last visit or last meeting that they wanted to bring up to maybe have us talk about in this TAC?
It sounds like transportation will continue to stay on the agenda. Is that right? I think that's really important.
Yeah. Yeah, we tend to get updates about it. I hadn't included it on this one. We had just got the presentation or the data over the like last week or sometime. I'd already submitted it, so I didn't include it, but knew I'd bring it up later. Okay. All right. It's a little early this time, but if anyone doesn't have anything going on, if any other additional topics, I don't know if you guys typically adjourn a little early sometimes or not. No. Any of the other TAC members on? Who we got? Dr. Batista, anything?
No, I just wanted to request to Dr. Giroux, her last 3 slides. I just missed one because I stepped on my cat, so I didn't see your slide, and then I got lost because she ran away. I'm sorry.
Erin, could you send the slides out to the
Yes,
TAC?
ma'am. I already have it in the email prepped, ready to send.
Thank you.
You're welcome. I couldn't find my mute button.
I was trying to see if Wanda was still on.
Yes, I am.
All right. So were you here earlier when we had covered a little bit about interpreter services and grievance processes?
Yes.
Okay. Was there anything, I know that you had mentioned to me asking for like a presentation from the MCOs. Was there anything from them that you were wanting specifically to see, or?
Yeah, I would like to see what is the process for each one of them. And I think that by the virtue of presenting, maybe we could identify how we can create a similar system among the MCOs, so people are not lost, whether they have to contact Humana or someone else, in terms of what are the steps. Sometimes it's help to simplify it. So I hope that, throughout the presentation that the MCOs are open to recommendations in terms of how to create a system that could be similar across their companies.
I think in this regard, I just support and second the request of Dr. Richardson regarding having one, base page for all the MCOs to contribute and work together. So the process would be easier independently or of which MCO the Medicaid patient is seeking assistance.
Right.
Would something like that be something that we could recommend to the MAC?
Correct.
A way for them to organize, something like that where there is just one system set up that's more accessible. You have another person with us, or was it just myself, Dr. Batista, Dr. Richardson, Dr. Vergaro? I thought someone else was here earlier. I guess not. I know, Dr. Fergar, you work primarily like your locations are with behavioral health type things, right?
Yes.
Okay. Anything on that side recently that I know that there's tons of things already ongoing. How often do you guys look at disparities in behavioral health outcomes as far as based on race and things like that? And what have you seen?
Well, behavioral health is a bit different than physical health in the sense that language is extremely important. It's not just another person translating because context is everything, and that's why we are advocating not only to have translators, but to be able to have a differential in reimbursement so we can attract bilingual individuals into our staff, into our because it helps more the patient when the provider is bilingual and doesn't have to rely on a translation or what are your symptoms, and then you run some labs and you determine whether this person have diabetes or not or whatever. With behavioral health, the nuances of languages are very important, and also the clinician base their diagnosis and their treatment strategies on what they see in the context of language, because it's you don't have a lab test that determine whether a person have depression or not, or schizophrenia, for example. So so the issue of language is extremely vital to us. We have seen growth in terms of the Burmese population and also Spanish-speaking population. And being in Western Kentucky is it's not Louisville, that which you have more diversity and probably a higher pool of healthcare providers who are bilingual. We experience the language barrier more so, I would say, in rural areas and places like the one that we provide services to. So, we look at the trends on an annual basis, but we also participate in a community needs assessment. For example, I'm part of the board of directors for the Owensboro Health Regional Hospitals, and we work closely with them. And the issues of language and access has been identified before as well. So they struggle with that as much as we do. I mentioned earlier, and a couple of months ago, the need to open the certification for people who are bilingual, that they can become interpreters. I know people that have tried to register for that, and it's very cumbersome, and they have not been able to do it. Maybe that's something that can be looked at. So the perfect scenario is that we will have clinicians who are bilingual, right? That we're able to recruit in and maintain them. But sometimes perfection is the enemy of good. Let's say that we have to rely on translations. Then I would say that as a system, we should look into expanding those opportunities, maybe doing public announcements about people that can become interpreters, because that will open the doors for hiring individuals in these areas. I don't know how many translators each MCO has,
Mm-hmm.
But how can they coordinate if they have 1, 2, 5, 10? I don't know. But we definitely need to have more, and it will be great. I mean, we cover 7 counties that we could get our own translators. or have differential reimbursement.
Yeah. Yeah, I mean, we had spoken about that earlier. I mean, that seems like the easiest solution is,
Right.
paying for that type of skill or for that specific
And some states,
person
for
leader.
example, I come from Illinois, they like for shower fare, for therapists and all of that, there is a differential in pay in the reimbursement. And because they know that you need to have the capacity.
Yeah. There was another thing we had a discussion about in a clinic a week or two ago. So at least based on the presentation we were given, is it like HPV throat cancers caused by HPV are like we're number one in the nation as a state for Kentucky on most recent data. I didn't know if with Rachel saying that they were going to review stuff for homelessness and things like that rather than rate specific to obesity and other things, but like obviously cancer would be another one to add in the future of rates to look at. And specifically once I seen that the throat cancer, with having things like Gardasil and vaccines that we use, which help, prevent throat cancer. I didn't know if we had any information on disparities in vaccination rates, specifically for Gardasil, but obviously for other ones as well. And if there are large differences in vaccination rates, which again, I'm sure there are, how do we think about improving that or decreasing that disparity?
Well, you bring up a very interesting topic because HPV vaccinations, it's been a hot topic on our side of things, and looking at measures for the adolescents and how or if providers are administering these vaccinations. And we do have a low HEDIS measure that measures this HPV, which is Dr. Terrio, what is it? Combo 10, I don't know. Combo that has the Tdap and HPV.
IOM2. IAM2.
Sorry,
right?
yes. Sorry, yes,
So, yes, so we have a very, we have a low measure as it relates to that and some of the challenges it is to get our children by the age of 13 having their immunizations for HPV Gardasil by that age. So looking into that area, whether or not, providers are just uneasy about discussing it because the sexual connotation to it, or if we've evolved from that or not. So I'll let Dr. Terrio, she's a little bit more well-versed in this than me, but this has been a topic of conversation.
We are asking everybody we can to improve their HPV rates, be it universities or MCOs or whoever, but they do push back because of saying it's associated with sex. I personally don't see that, and you guys who are pediatricians also can't imagine. I think it honestly is the provider not wanting to take the time and to bring it up and to have a conversation with the families, and that's tougher to get around, I think. So I really think we have to do some provider outreach or education or whatever you want to call it, to have them, number one, accept it as a routine vaccine like polio or diphtheria, and treat it like that, like every other vaccine, and therefore they will have the conversation with the parents and the families to get it. But I'm appalled that it is such a problem. I think it's absolutely ridiculous. it's crazy that you wouldn't want a vaccine that protects you from cancer. And so that's why I think doctors just aren't discussing it with their families.
That's good.
And
Yeah.
just to add to that, I think there's probably there's two big arms of opportunity. One is what Judy's talking about. The other is if you look at the people who have had one, but they just didn't get their second by age 13, that's a huge number. And those parents want it, but we're not making sure they get it, right, as a healthcare community or the public health community. So, and those are the easy ones. They want it. So if we could just knock that, our HEDIS rate would improve tremendously if we could just get that second dose in for people who actually want it. And focusing a lot of energy there, I think would be really helpful. We don't know. I can't run a report and find my people who need a second.
I guess it gets down to what Dr. Franco always said. You know, every time a child comes in, you should look at their shot record and give them one if they need it. I
think they're just not coming in, right? So they come in around 11 and a half, close to 12 for that 11-year-old checkup. They get their first one. And then they come in when they're 13 years, 1 month for their second one. Yeah. So it's just such a narrow window. Now we're trying to start at 9, but that's hard to remember to do so you can get that second one in by 11. But yeah, it's just that so many kids don't come in between 11 and a half and 13. Right. They might come in 11 and a half and 13 and a half, but it's that there's just a little gap in there.
Well, we started at CNY at 9 and we had great results. And
I don't know if there's, sorry.
No, it's just, we just have to, get everybody on board in the clinic in case the doctor forgets about it.
I think what you said about education is like some type of campaign or something regarding HPV vaccination. The rate of HPV vaccinations versus the rate that decline when I bring up HPV vaccinations is at least 60%, right? What are our rates, like 20% or something like that, if that? And I maybe have 1 in 20 patients tell me, that they are against HPV vaccination, maybe 1 in 10 when I bring it up, right? Because I discuss it as a way to prevent cancer, and that's how it should be presented. And a lot of times, if I have older kids that aren't vaccinated for it and I mention it, they were never offered, or they just they weren't educated on it. And so I think I've had some patients tell me, that they had saw a provider before that had recommended against it, right? And like that is why the number's so low, right? It's not that there is a 80% of people against preventing cancer, right? It's just that we know that's not the number, right? If you went out and asked 100 people, would you like to prevent throat cancer? I think they're all going to say yeah, right? It's not asking, and it's not having people that are educated who are the people that should be vaccinated to begin with. And that is a drastic number, and I don't think we realize how many providers aren't educated on the vaccine as well. So I don't know how we could fix that statewide, but that's definitely a problem.
And then we're considering the kids that come to the offices to see the pediatricians. But we have also to think about all those that don't come to the offices, we still have to battle against the belief that I don't have to go to the doctors unless I'm sick, and even if we talk to the parents, unless they are sick, they won't bring their kids. So having a family to bring kids just for a well check and then for vaccinations, it's another field that we have to really work at, and particularly with refugees and also with migrants.
Yeah. It's something else, but I completely slipped now. Oh, for health departments, when they do their vaccines, because I know a lot of patients go through health departments as well. I'm sure they have the HPV vaccine there. Is that part of when they go in and just say their 11-year-old shots? I'm sure it's offered, but I don't know if there's I don't know. I don't know with who's giving it and things like that, how that's presented as well when they're going through there. Because it's not technically one that's required by the school. I don't know if it's also recommended at the time when they're coming in for their 11-year-old vaccines. I'm sure at places it is, but I don't know if that's a thing that's actually set up for all the health departments that, you know, we recommend that at each 11-year-old visit when they're getting those shots or thereafter if, again, because if they didn't get it offered at 11 and they're coming in for their 16-year-old meningitis or something, it's still, you know, bring it up again. Just because, you know, they didn't get it at 11 doesn't mean that they said no. They may have never heard of it. So yeah, that's something I see.
I hope they are. If not, Dr. White's gonna find out about it and I hate to be in their shoes.
Right. It's, yeah, that's a soapbox that we could all get on. Okay. Well, we don't have enough people here to vote for anything, but if no one else has a topic to bring up, I guess we will adjourn for this one. Our next meeting is on the 20th September. I've got the old thing pulled up that I've been reading from. November 1st. There's also participation in the registry. Yeah. Oh yeah. The other people, that's another problem. I feel like most clinics are on board with putting things on the registry now, but there are some that definitely do not, and I have to call and get the vaccines from them. So our next meeting is on the 1st of November. If everyone is good with it, we'll go ahead and adjourn.
Thank you.
Thank you, guys.
Thank you.